So now we are going to move on to Chapter 6, which will cover injury, inflammation, healing, and repair. So there are many different pathological events that can cause cellular injury. We're going to first begin our discussion by talking about ischemia. And ischemia occurs when blood flow is insufficient to maintain cellular homeostasis and metabolic function. And ischemia usually occurs because of some type of atherosclerosis or the presence of a thrombus. And these events that happen could lead to a myocardial infarction and or a stroke happening. So I do want you to know the differences between hypoxia and anoxia. Whenever you see a word with the letter A in front of it, that means without. So anoxia is a complete reduction in oxygen supply compared to hypoxia, which is only a partial reduction in oxygen supply. So in our body, we have these processes, these metabolic processes that allow us to rid the body of waste, rid the body of metabolic byproducts that we do not longer have any more use for. So the first one is known as the ubiquitin protease system, or ubiquitin proteasome system. It's also called the UPS system. So 80% of the cellular proteins that are degraded and removed from our body go through the UPS system. United Postal Service. I think of the United Postal Service delivers everything everywhere. United Postal Service in our body is kind of going in and cleaning out all the junk that we no longer need. The other cellular process that allows us to remove toxins and metabolic byproducts from our body is known as autophagy or autophagy. And we're going to discuss this a little more, but for now, auto means automatic and phagy means eating, so automatic eating. And we're going to talk about some of the players involved, the lysosomes, the phagosomes, and how those all come together. So we always talk about the benefits of aerobic metabolism. So aerobic metabolism, this happens when we're actively exercising. If we lose the capability to exercise aerobically, we are going to have what is known as decreased ATP synthesis, adenosine triphosphate synthesis. And what could happen in this condition is there could become an accumulation of ions and fluid that builds up intracellularly. And what would happen in the cells would begin to swell, and then their overall function would become compromised. So there are numerous causes of both hypoxia and anoxia. Just a few I want to mention here. Hypoxia and anoxia could both be caused by the obstruction of the respiratory tree. This is what happens when you suffocate if you unfortunately drown in some event. Another thing that could cause both hypoxia and anoxia is the inadequate transport across the lung surfaces. So this occurs when we have pneumonia, and an inadequate transport of oxygen in the blood. This could result in a condition known as anemia. And think of one of the ways suicide happens through carbon monoxide poisoning. What happens in carbon monoxide poisoning is the body is no longer able to use oxygen for cellular respiration, and the body will begin to shut down. So what is the underlying pathology, or what causes the cells to become injured in the first place? Well, there are many different mechanisms which could cause cellular injury. First, let's talk about some infectious agents. I'm sure many of you, or if not all of you, including myself, has had some type of infection at some point in our life. One of the most common forms of pneumonia infection is due to Mycoplasma pneumonia. Athletes, anybody who's played basketball or football or baseball or any sport really that's had to wear a tight shoe, and you sweat a lot in sports, so you could develop a fungal infection known as athlete's foot, and the organism that mediates this function is known as Tinea pedis. Another type of infection could come from protozoa, could also be prions in the brain. Prions are misfolded proteins, and could lead to multiple diseases, which we're going to talk about later in the course, such as Creutzfeldt-Jakob disease. And The helminths. The helminths are the tapeworms or the nematodes, and we'll talk about those more as well. So we've talked about the infectious agents, the bacteria, the viral agents that could cause this. There could also be a genetic component. Some people are more susceptible to developing diseases based on their genetic imprint. If you're not eating the proper nutrients, if your body doesn't have the fuel that it needs to propel itself to prevent these infectious diseases and combat these infectious diseases once they're internalized, then we could also have cellular injury occurring. So there's a whole process where cellular agents will release both exotoxins and endotoxins. These are, as the name implies, they're toxins, so they cause cellular lysis. It causes the cells to break down and degrade. So we're going to get into the mechanisms a little bit later, but for now I just want you to know that these viral agents all release both exo and endotoxins, and they cause cellular lysis as well as degradation. So I really like this slide a lot. This slide is a little complicated, but if you break it down step by step, it's very insightful. So let's begin at the top left-hand corner talking about normal cell homeostasis. So how does cell injury occur? Well, we've covered a few mechanisms through viral agents or bacterial agents. So there's some type of injurious stimuli that will cause cellular injury to occur. So we can either adapt to this, and the injury could be a mild transient injury and we can heal rather quickly, or the injury can progress and become more severe and eventually lead to an irreversible injury. There's two main types of irreversible injuries. There's necrosis and there's apoptosis. So apoptosis, this means programmed cell death. We have certain cells in our body that are programmed to die after a certain amount of time, such as the red blood cells. So our red blood cells are made in our body, and after about 120 days, that's their typical lifespan, they have to be broken down to allow for new red blood cells to be generated. Necrosis happens when there's some type of injury and the tissue basically undergoes a rotting procedure. And we're going to talk about dry necrosis, liquefactive necrosis, things like that later on as well. So whether or not the injury is reversible or irreversible, what determines that? So if the injury is reversible, it depends on if the body is able to withstand the derangement of the homeostatic mechanisms and have the capability to adapt to this new pathologic state. Can the body have the necessary ability to return to the state of original homeostasis or not? And reversing the injury and achieving homeostasis are both determined by a combination of factors, including the mechanism of the injury, the length of time of the injury, and whether or not there's any intervention. Did you seek physical therapy? Did you seek surgical intervention? Things along those lines. And also the severity of injury. Depending on how severe the injury, sometimes the injury is so severe that we really can't come back from it. So take some time, go through this slide, look at how a normal cell gets injured and the two pathways it could take. It could either become a reversible injury, or it could be an irreversible injury and eventually leading to cell death. Sepsis is a potentially life-threatening condition that is caused when the body responds to an infection. The body normally releases chemicals into the bloodstream to fight infections, and sepsis can occur when the body's response to these chemicals is out of balance, which will trigger changes that can damage multiple organ systems. So as you can see from this picture here, sepsis is categorized into a very complicated series. So we have SIRS, we have sepsis, we have severe sepsis, and septic shock. I'm not going to need you all to be able to differentiate from that. I just want you to know what sepsis is and be able to recognize septic shock. So during septic shock, you may have a patient with severe hypotension, so a very low systolic blood pressure below 90 millimeters of mercury. And you'll have signs of end organ damage here. The patient may be experiencing some type of altered mental status, and there may be a need for a ventilator. So sepsis is caused when some type of microorganism releases both or either its endo or exotoxins into the blood and causes all types of damage. So there could be endothelial cell damage, which could lead to a loss of plasma volume, which could lead to hypovolemia. Again, I don't need you to know all these mechanisms. I just want you to know the general outlook of what sepsis is, and know that sepsis can result in severe organ damage and some of the signs that are present when you see a patient in septic shock. And again, those signs include a low blood pressure, possibly an altered mental status, and also the patient may be breathing abnormally. So the patient may need a ventilator. So viruses can infect the human body in one of two ways. Either they can have a direct cytopathic effect, or they can have an indirect cytopathic effect, which is mediated by different immune mechanisms. And this is significant for the physical therapist to be able to differentiate between, because you will, if you are able to differentiate between these two, you'll be able to know how the disease manifests, and you will be able to help the healthcare team in remediating whatever condition the patient may have. So a direct cytopathic effect, this is what we see in RNA viruses. And what happens here is it directly disrupts cellular processes and it destroys integral cellular components. So you may have membrane blebbing, you may have damage to intracellular compartments such as the lysosomes, the Golgi apparatus, things of that nature. And then the indirect mechanism is mediated by immune mechanisms and virally encoded proteins that become inserted into the plasma membrane of the host cell, which form a channel and alter the permeability of the cell membrane to ions. So ions can come in and out of the cell. In neuro, we'll talk about the action potential of how potassium and sodium enter and leave the cell, which generate different stages of polarization. And in the indirect mechanism, as this altered cell membrane permeability occurs, this results in the loss of the ionic barrier. And again, this can cause cellular swelling and death to occur. So the DNA viruses encode the production of foreign particles which are exposed on the cell surface and recognized by the body's immune cells. And later on in the immune section, we're going to talk about all the different players of both the adaptive and the innate immune system. But for now, T lymphocytes are part of the adaptive immune system, and they help to recognize the virally encoded proteins, and then they attack and destroy the infected cell. But when the immune system is compromised, the invaded microorganisms can overwhelm the body, and that's when disease actually occurs. So this slide, I'm not going to test directly on it. It's just more for mechanistic purposes. So I kind of just want you to know what's going on here. The direct cytopathic effect is depicted here, and what happens is the RNA virus is going to insert itself into a receptor on the cell membrane, and then it's going to be brought into the cell. The RNA virus is then altered into DNA through a process known as reverse transcriptase. And those of you who have a molecular biology background, you'll know what complement DNA is and know the whole process of reverse transcriptase. We use this process when we do real-time PCR in molecular biology. After the virus is altered into DNA, the DNA within the nucleus of the cell forms various types of RNA that allows for protein synthesis in the rough endoplasmic reticulum. So you can remember from your basic undergraduate classes, the differences between the rough endoplasmic reticulum and the smooth endoplasmic reticulum is that the rough endoplasmic reticulum is studded with those little dots known as ribosomes. And that's where our RNA is produced, ribosomal RNA is produced. So once we're in the rough endoplasmic reticulum, the protein that is formed inserts itself into the cell membrane, and that forms a channel that allows ions and extracellular fluid to enter. And this leads to cell lysis by directly killing the cell. So like I mentioned earlier, there are many different things that could cause cellular disease and injury. Let's talk about general allergy. So many of you have just moved to a new location, bright, beautiful, sunny Florida. However, many of you have probably not been exposed to the massive amount of pollen that we have in the air. So pollen will basically cause our body to elicit an allergic response if we're not used to it. And you can also develop allergies later in life. Something that you may not have been allergic to when you were littler or smaller, you might develop an allergy to later in life. And so what happens is your mast cells and your basophils are going to be releasing histamine, and this could cause you to have a runny nose or watery eyes, etc. And like we mentioned, hypoxia caused by asthmatic bronchoconstriction. When somebody's having an asthmatic attack, we give them a nebulizer, some type of inhaled corticosteroid like albuterol to allow the person to breathe normally again. And we're going to talk about that more in Cardial Pulm with Dr. Nuzzo. So another mechanism that can compromise the immune system is cross-reactivity. So if there's any type of talk between some type of streptococcal infection and a myocardial antigen that may be present, this occurs in a condition known as rheumatic fever. The crosstalk between the streptococcus and the myocardial antigens can result in an injury to the cardiac valves and can cause heart complications. And any type of chronic persistence of a foreign antigen by a foreign body or microorganism that cannot be cleared by the body may lead to a granuloma. This is what you see in tuberculosis. And the term sensitization, so what does that mean? We get sensitized to something, we get exposed to something over and over and over again, our body becomes more or less sensitive. It all depends on genetic makeup. If we have more of the antigen present, we may become more sensitive. It all depends on the pathological conditions. So sensitization can lead to type 1 diabetes caused by destruction of the islet cells by the T lymphocytes. And the T lymphocytes become sensitized by islet antigens released during some type of antecedent viral infection. Also, there are many different types of chemical factors that can induce cellular injury. And if you look at the schematic here, this schematic is from your Goodman book, and this is the process of free radical generation. You don't need to know the process of free radical generation, but just know that free radicals are harmful to the body. And free radicals can be generated through many different means. They're continuously formed in the body as they are a part of normal pathological reactions, but if they accumulate, they can become damaging. And when they accumulate and become damaging, this is known as oxidative stress. So you can also generate free radicals by ingesting any type of metal, so mercury and any type of alkylating agents that are used in chemotherapy. So how can you ingest mercury without even knowing it? Well, fish, or especially fish that are predatory fish, the ones higher up on the food chain, those are the ones that have higher mercury content in them. So if you eat a predatory fish such as a barracuda or a shark, you're ingesting a large amount of mercury. So just limit your barracuda and shark consumption. The alkylating agents used in chemotherapy, such as the drugs cisplatin and daunorubicin, those work by cross-linking DNA. We'll get into more of that later. So free radical generation is a normal metabolic process, and there's a variety of other extrinsic factors such as pollution, poor nutrition, and exposure to toxic chemicals that can cause free radicals to form. And basically what happens in free radical formation when the body is exposed to these toxic chemicals, the normal oxygen atoms will lose one of their 4 paired electrons. And then this results in an unstable atom which attempts to replace the missing electron by stealing an electron from some healthy cell. And then when that cell goes to steal the electron, this creates another unstable atom, which is another free radical. And then this process kind of sets off a catalytic domino effect or a chain reaction that's known as oxidation. And oxidation as a byproduct of metabolism damages cell membranes and leads to intrinsic cellular damage, but this is also a part of the normal aging process. And free radical damage or oxidation is believed to alter the way cells encode genetic information in the DNA, and it also may contribute to a variety of diseases and disorders. Antioxidant molecules freely give up an electron to stabilize the oxygen atom without becoming unstable and without initiating a chain reaction. So you may be asking yourself as a physical therapist, why do I need to know this? Well, free radical generation can lead to heart disease. It can lead to cerebral vascular disease. Diabetes mellitus could result in cataracts. It could cause the neurons to degenerate that are associated with the substantia nigra, which will be associated with resulting in Parkinson's disease. And if we're damaging the neurons that are located in the substantia nigra, we're going to lose dopamine. And dopamine is necessary for not only mood stability, but also to control normal movements. And so if we lose dopamine, you're going to get a lot of abnormal movements, such as the ones that we see in Parkinson's disease. So this slide is more for your general knowledge. I'm not going to test on any specific antioxidant, but I do want you to know that there are both endogenous and exogenous antioxidants. And there are many different foods that you can eat to help limit free radical generation in your body and help to keep you healthy. So the simultaneous presence of antioxidants is an adaptive response to help the body ward off the potentially harmful effects of oxygen and its derivatives, and this includes the free radicals. So exogenous, this means to come from an outside source. So the exogenous antioxidants are vitamin C, vitamin E, and beta carotene. And there have been over 200 identified exogenous antioxidants that have shown benefit to the human body. Another one is lycopene. Lycopene we get from red tomatoes. This is shown to facilitate good prostate health. And beta carotene and copper significantly slow the progression of age-related macular degeneration. So just scope out this schematic, make sure that you're getting several different types of antioxidants. I do want to draw your attention to the acerola. Many of you may have not heard of the acerola cherry. This is a plant that's native to several parts of South America, including Brazil and Peru. And the acerola cherry is really awesome. I actually have a tree in my backyard, and one cherry is said to have 8 times the amount of vitamin C that one orange has. So it's a great source of getting antioxidants, and they actually taste really good. I'm a big fan of them. Now we move to nitric oxide. Nitric oxide, or NO, is very important in facilitating long-term memory generation. And nitric oxide is a free radical which modulates a variety of physiological activities, and this is present in all mammalian species. What it does is it increases permeability in our neurons, and for instance, this makes acetylcholine transfer across the synapses easier. We're going to talk about the different neurotransmitters in neuro, but for now, acetylcholine is really important in muscle function. Without acetylcholine in our neuromuscular junction, we would not be able to extend or contract or flex or do anything with our muscles, basically. And the way nitric oxide increases neuronal transmission is it increases the permeability of the terminal nerve endings. And it also has the capability to alter the gastrointestinal mucosa to resist injury induced by any type of toxins. Thereby, it influences the immune system. It also stimulates collagen synthesis for wound healing, and it's an anti-lipid. So what does that mean? It basically is anti-fat, so it provides a non-stick coating to the lining of our blood vessels. So if there's anything, if there's any fat breaking off, traveling through our blood vessels, it'll just slide right through so it doesn't get stuck, and so that we don't get any type of arterial or atherosclerosis forming. And the big point I want you to know is that decreased nitric oxide bioavailability is associated with risk factors for cardiovascular disease. So, like, again, everything in moderation, but we need nitric oxide to be bioavailable. And if we have decreased nitric oxide bioavailability, then we have an increased risk for developing cardiovascular disease. So these 3 bullet points: nitric oxide is essential for the formation of long-term memory, it aids in neuronal transmission, and it's an anti-lipid. I want you to know those 3 bullet points for nitric oxide. So now we're going to move out of the cellular component, and we're going to talk about different types of genetic abnormalities that may result in cellular injury. So what happens if we have an alteration in the number of chromosomes we have? What if we have an extra chromosome somewhere? Can anybody think of a condition where we have an extra chromosome? If you think of the condition Down syndrome or trisomy 21, well, we have an extra chromosome at the 21st loci. And people with Down syndrome experience mental delays. They also have an increased risk of leukemia, a specific form known as acute lymphoblastic leukemia, and they're more susceptible to developing Alzheimer's disease and dementia. Could also have single gene mutations. So a single gene could alter a single protein that may wreak havoc on the body. So for instance, the HBB gene, the hemoglobin B gene, is altered in sickle cell anemia. And this one gene, man, it really messes up the body with sickle cell. Sickle cell anemia causes patients to have recurrent respiratory infections, problems with blood transport, so on and so forth. Other conditions that result from single gene mutations include LDL, low density lipoprotein receptor deficiency, alpha-1 antitrypsin deficiency. In alpha-1 antitrypsin deficiency, what happens is there's a degradation of elastic tissue around the lungs, which could lead to emphysema. And alpha-1 antitrypsin can be present in adolescence and even in early childhood, and this can result in little kids having strokes. And then, as you all may know, if there's something going on in the body, there's probably something else going on in the body to combat it or try to help facilitate a remedy for it. So there's multiple gene mutations that may interact with each other, and there's also multiple gene mutations that may interact with the external environment. So, for instance, hypertension. Hypertension is a multi-causal pathology. Well, we don't really know exactly what causes hypertension in every single patient, but patients with hypertension usually have more than one pathology present in their body. And type 2 diabetes. What's going on with insulin receptor sensitivity? What's going on with glucagon production, insulin production, metabolic absorption and excretion of these different products? So just know that there are multiple players in some pathologies, and there is a large pool of genetic factors that play a prominent role in developing pathology. Mechanical factors also play a prominent role in cellular injury. The physical stress theory tests the hypothesis of whether or not changes in the relative level of physical stress can cause a predictive or predictable adaptive response in all biologic tissue. So, is physical stress good or is it bad? Well, there's pros and cons to it. So, you're a runner, and you've been running for X amount of years, you're very physically fit, and all of a sudden you develop some type of injury. Maybe you sprain your ankle or you pop your Achilles tendon, so you have to take time off. Well, if you're not doing anything and you're just taking all that time off, your muscles aren't going to be worked the same, so they're going to undergo a process known as atrophy. On the other end of the spectrum, look at bodybuilders. So how do we increase our muscle strength? Well, we do more weight, or we have to do more repetition. So you have to increase your stress tolerance. So a bodybuilder may be able to bench press 400 pounds, and they go up to 420, and then they go up to 450. So this increased stress tolerance is causing the muscles to hypertrophy. And you remember from your anatomy lecture, the bench press, you really get significant hypertrophy of your pectoralis major and your pectoralis minor. So with the pros, with the hypertrophy, you could also injure yourself. Tendons, ligaments, and muscles can only sustain so much, and you have to undergo proper stretching and proper treatment, and allow your muscles time to repair. Don't work out super intense every single day. Give your body some time off and allow it to rest. And what we see in the elderly, we usually see a decrease in mechanical stress, and this could lead to bone degeneration. So that's why it's very important as a physical therapist to encourage the elderly to do weight-bearing exercises. So what about repetitive and forceful tasks? Well, repetitive tasks, that could initiate the stimuli for an inflammatory response, which includes repeated overstretching. This could lead to compression fractures. This could lead to excess friction and also anoxia. And then we want to encourage a controlled increase in physical stress. So only do what you can. Muscle hypertrophy and greater force generation will occur as your muscles begin to get used to your routine. So remember, as physical therapist, you're helping someone who's come off of some injury most of the time. You're helping them get back to normal form, so it's really important to do a controlled increase in physical stress. There are also nutritional, physical, and psychosocial factors that contribute to cellular injury. Even though you may not see these two conditions that are depicted on the screen in the clinic in North America, if you ever do any pro bono clinic work overseas, you may see them. What's depicted here? The child on the top left-hand corner with the protruding abdomen. This is known as Kwashiorkor syndrome. And Kwashiorkor syndrome occurs in people who have a severe protein deficiency. And then you look at the little boy in the bottom right-hand corner. This is marasmus. Marasmus is a complete calorie deprivation. So you can see this little boy, unfortunately, is very emaciated, and compared to the boy in the top left-hand corner of the screen, you can look at his arms and his legs are very skinny, but he does have that protruding abdomen. And you can identify kwashiorkors from marasmus most of the time due to protruding abdomen. You may also see edema or puffy or swollen general appearance in kwashiorkors due to the fluid retention. And both of these conditions may cause the patient to not be able to gain weight. So you're at an increased risk for kwashiorkors if you live in a rural area where there's limited access to protein-rich food. So children who develop this are mainly on a high carbohydrate diet. Maybe that's all they're getting for a single day is a small bowl of rice. And it's very sad and unfortunate. Children who have been weaned off of breast milk are also at an increased risk if they don't have access to protein-rich foods. So again, the top left-hand corner with the protruding abdomen is kwashiorkors, and the one on the bottom is marasmus. So again, marasmus, all nutrients, including the proteins, are deficient. And this occurs more in the young children and babies. It also leads to dehydration and weight loss. And starvation is a form of this disorder. The symptoms of marasmus include severe weight loss, dehydration, chronic diarrhea, as well as stomach shrinkage. Studies have shown that people who describe their work as monotonous have a higher risk of injury than those who are satisfied with support from their colleagues and supervisors. So that gets into the bottom portion of the screen where we talk about fear and tension and anxiety. So fear and tension and anxiety can also induce cellular injury. So try to limit your fear, your tension, and anxiety as much as possible, and try to incorporate a nutritionally adequate diet every day of your life. So now we move on to cellular aging. Cellular aging, again, there are many theories that still exist. For instance, there's the wear and tear theory. The wear and tear theory basically states that Our body can undergo only so much mechanical stress, and our cells can only undergo so much mechanical and oxidative stress before they no longer function. There's also the free radical theory. And the free radical theory is based on the chemical nature and wide presence of free radicals that cause DNA damage. One really interesting one is the telomere aging clock theory. So in biology, when you talk about meiosis and mitosis, we talk about the different phases of prophase, metaphase, anaphase, and telophase. Well, what's happening in telophase is the telomeres are involved. And as long as the telomeres are dividing, the cells will remain healthy. But as the telomere division slows or reaches cellular senescence, the cells will also die slowly. And again, this is just a theory. And like you see on the slide here, there's over 300 theories that exist about why cellular aging occurs. So nobody really has the definitive answer. The bottom left-hand picture is an image of an electron microscope. So again, diagnostic imaging, objective, objective, objective here. And you can see this kind of black stain in the middle of the organelle. And this is known as lipofuscin. And the presence of lipofuscin is the most well-described age-associated change in the subcellular structure. And what you're looking at here is you're looking at an electron microscope of a lysosome. And remember, the lysosomes are involved in the cellular degradation process with autophagy. And lipofuscin, this black pigment, is an aging pigment granule that is found in high concentrations in old cells. So as our cells age, you're going to see more and more lipofuscin. So as you can remember from the introduction slide, cellular injury could result in the injury being reversible or irreversible. So we're going to talk a little more mechanistically now about reversible cell injury. And again, there's many different mechanisms that could induce reversible cell injury. Basically, what happens to the cell during reversible cell injury is there's an influx of interstitial fluid into the cell, and this accompanies the different types of ions that may be coming into the cell, causing ionic shifts and ionic imbalance. And all this fluid and these ions coming in, it causes the cell to swell. Swelling occurs within the cytosol, and it affects the organelles. So you can think of the organelles that are located in the cytosol, such as the mitochondria. What do the mitochondria do? Well, the mitochondria produce ATP, or adenosine triphosphate. And if the mitochondria are swollen, they're not able to produce ATP as effectively, well, they are going to ultimately generate less energy. And if there's less energy getting generated, the cell may convert to anaerobic glycolysis and produce lactic acid. So the injured cell could form plasma membrane blebs that could seal off and detach from the cellular surface. And in severely injured cells, ribosomes can detach from the rough endoplasmic reticulum, and a decrease in the number of polysomes can occur. And this could result in a dramatic reduction of protein synthesis. One thing I really want you to know about reversible cell injury is that there's no damage to the nucleus of the cell. All the damage is occurring in the cytosol. So no damage to the nucleus, and when the cell begins to repair itself, the energy source will be restored, or the toxic injury becomes neutralized. And then the cell is able to recover and pump the ions and excess fluid back out. Then the swelling will disappear, and the cell is able to return to its original steady state, and this whole process constitutes a reversible cell injury. So on the previous slide, I talked about the acute reversible cell injury. So now let's move into a little bit more of the mechanisms and the adaptations that the body undergoes during a chronic cellular injury. So there may be some type of prevalent sublethal stress, and the body has to undergo some type of adaptation to avoid long-term injury. So what are these adaptations that the body undergoes? So what is hyperplasia? Hyperplasia is simply the increase of the number of cells, increase in the number of cells. Hypoplasia is a decrease in the overall number of cells. Also, hypertrophy versus hypotrophy. So pure hypertrophy only occurs in the heart and striated muscles because these organs consist of cells that cannot divide. Hypertrophy of the heart is a common pathological finding that occurs due to an increased workload. And we also have the condition known as atrophy, so the decrease in muscle size and muscle volume, muscles basically wasting away. Metaplasia, this is the conversion of one cell into another. So give me an example of when metaplasia may occur in the body. Well, if you think about somebody who smokes, the ciliated pseudostratified columnar epithelium cells may become stratified squamous epithelium, and this will lead to a thickening of the respiratory epithelium and eventually a loss of the functional clearance of mucus and debris along and throughout the respiratory tree. And then what's dysplasia? Dysplasia is an increase in the cell numbers that is accompanied by altered cell morphology and loss of histologic organization. So I do want you to know the different definitions. I want you to be able to differentiate between hyperplasia, hypertrophy, metaplasia, dysplasia, and atrophy. Remember, pathologic atrophy occurs as a consequence of cellular injury due to ischemia, inadequate nutrition, or physical factors such as bone loss or muscle wasting and brain cell loss. These are all examples of either tissue or organ atrophy that are associated with aging. So if we look at this picture here, the brain on the left side of the screen is a normal brain from a young adult. However, if you look at the brain on the right side of the screen, you'll see a lot of space in between the different gyri. And this is a brain that's undergoing atrophy from a person who is deceased, an 82-year-old man with a condition known as atherosclerotic cerebral vascular disease. You don't need to know that disease. I just want you to be able to recognize brain atrophy compared to a normal brain. In this specific condition, in atherosclerotic cerebral vascular disease, this results in a reduced blood supply to the brain. And you can also see the anatomical changes that occur, as I mentioned briefly earlier. The gyri are narrowing and the sulci are widening. And in both of these pictures, the meninges have been stripped away from the right half of each specimen to allow for visualization of the surface of the brain. So now we're going to move on from reversible cell injury to irreversible cell injury. And irreversible cell injury is synonymous with cell death, so cells dying either due to apoptosis, programmed cell death, or necrosis. So apoptosis begins with either an activation of a trigger or stimulus or the suppression of a specific agent that then allows for the process of cell death to occur. It's typically not associated with the inflammatory response like necrosis is. And necrosis is the active process of degradation of dead cells. There are a lot of different terms depicted here. For instance, pycnosis. Pycnosis is the degradation of the cell as the nucleus shrinks in size and the chromatin condenses to a solid mass. During pycnosis, the pycnotic nuclei can fragment. This is the fragmentation process is known as karyohexis, and it can undergo dissolution known as karyolysis. So again, I don't need you to know all of these different defining factors of necrosis, but of apoptosis. But I do want you to know what is programmed cell death that's supposed to occur and what is not supposed to occur. So apoptosis, programmed cell death, that's supposed to occur. So our red blood cells, they have to die every 120 days and be replaced by fresh red blood cells. Necrosis occurs when there's some type of injury. It may be some type of pathologic injury, could be mechanical, could be bacterial or viral like we mentioned. Anyways, after cell death occurs, the lysosomes will release their digestive enzymes within the cytoplasm of the cell, and this initiates enzymatic degradation of all cellular constituents. And then the dead cells are released they release their contents into the extracellular fluid. Again, we'll talk more mechanistically, but again, that's just for your general knowledge. You don't need to know everything here. This table is just a good comparison of the events that occur under apoptosis, programmed cell death, versus necrosis, unintentional cell death. This picture here basically summarizes the chart from the previous slide. You'll see necrosis on your left and apoptosis on your right. Again, remember we mentioned the apoptosis is usually not associated with cellular inflammation like necrosis is. So apoptosis, the cell is going to fragment, and then eventually the phagocyte is going to engulf the apoptotic cells and fragments and dispose of it. In comparison to necrosis, the progressive injury that's causing the necrosis, there's going to be some inflammatory response occurring, and the breakdown of the plasma membrane and other organelles is going to occur. The nucleus is also going to fragment and break down. This is going to leak contents into the extracellular fluid, and the cell is going to be in this line of cascade of items that are going to prolong the inflammatory response in the body. And if it prolongs for an extended period of time, you're going to reach a more severe necrotic event. And we're going to show pictures of necrotic events that do occur due to prolonged cellular stress and cellular injury in a few slides. So there are multiple different types of necrosis, and I want you all to be able to identify and recognize the different types. So to begin, necrosis is the death of body tissue. It occurs when there's too little blood flowing to the tissue, and this can be from injury, radiation, or chemicals, or other sources, such as pyogenic bacteria infections. And this process cannot be reversed. So whatever is causing the necrosis, in order to stop the spread of the necrotic tissue, whatever pathogen is there, removal is a must. We must get rid of that pathogen. And then you can see on the slide here, the top picture on the far right-hand side, this is a brain section, and the picture on the bottom right-hand corner is a wedge-shaped kidney section, and you can see the infarct on the kidney. So these are depicting two different types of gangrene, and gangrene is a negative sequelae of necrosis, which is caused by a bacterial infection and is associated with tissue ischemia. So the top picture of the brain is showing wet gangrene or liquefactive necrosis, and liquefactive necrosis is caused by pyogenic bacteria such as Staphylococcus aureus. And what's happening here is the neuronal components of the brain, the neurons, they are dying because they're releasing lysosomes that are going to liquefy a specific area where the infection is. And when the neurons release lysosomes, this leaves pockets of liquid and cellular debris, and abscesses can form in these areas. It leaves the area shapeless, and amorphous debris remains. Wet necrosis or liquefactive necrosis can be found in the brain tissue, in skin wounds, and also in joint infections. The bottom picture showing the wedge-shaped kidney shows, you can see the yellow area, the kidney infarct. This is coagulative necrosis, and this is caused by ischemia or lack of blood supply. You can see that in most coagulative necrotic tissue, the cell membrane is preserved, and the nucleus undergoes pycnosis and also karyolysis, which is also known as dissolution. The organelles dissolve, and this process occurs in solid organs such as the heart, liver, and kidneys. Three more types of necrosis are depicted here. If you direct your attention to the picture in the upper right-hand corner of the screen, this is caseous necrosis or cheesy necrosis. So you can kind of see like this curdled cheese appearance. This is actually tuberculosis of the lung caused by the pathogen Mycobacterium tuberculosis. And caseous or cheesy necrosis can also be seen with fungal infections. And what happens is the cell membrane is destroyed, and debris appears in a cheese-like fashion and does not ever disappear due to any type of lysis or anything, but it persists indefinitely. And the damaged area becomes walled off in a fibrous calcified area, forming what is known as a granuloma. And caseous necrosis occurs in the lungs, the bronchopulmonary lymph nodes, as well as in the skeletal bone. The picture in the medial or the middle aspect of the screen is also known as fatty necrosis. So this is actually a picture of the mesentery, and fatty necrosis can be caused by acute pancreatitis or abdominal trauma. And what happens in fatty necrosis is there's a formation of calcium soaps by the release of pancreatic lipases, and again, this occurs in the abdominal area. And then the picture in the bottom right-hand corner of the screen, this is fibrinoid necrosis. So this is actually a picture of a blood vessel, and it's caused by a cross-section of the blood vessel, and fibrinoid necrosis is caused by trauma in the blood vessel wall. And what happens is the plasma proteins are going to accumulate, and the cellular debris and serum proteins will form different pink deposits. And again, this occurs in blood vessels, specifically in the tunica media, and it can also occur in smooth muscle cells. So as a physical therapist, you are all going to come into many patients in the clinic that are going to exhibit signs of inflammation. So you're going to have to be able to recognize them. So for those of you that know Spanish, it's very easy to learn the 4 cardinal signs of inflammation. So they are rubor, calor, tumor, and dolor. So let's break those down for those of us who don't know Spanish. So rubor, that's redness or erythema. And the erythema can be due to some type of vasodilation and any increased blood flow to that area. So in inflammation, why is blood going to that area? Well, we have all the inflammatory mediating cells that are trying to combat this infection or what have you going to that area. So you're going to have increased blood flow. We're going to talk about chemotaxis and diapedesis later, of how these events also precipitate and mediate the increased blood flow. So also the color or heat. So that area that's showing that erythema or that redness may also be very hot to the touch. Patient may be very sensitive. So if you're palpating that area, just be very careful of what you're doing at that time. And the heat may also be due to vasodilation and increased blood flow. The edema or tumor, what is a tumor? Tumor is something that's abnormal, large, maybe a swelling in a specific area. So the edema is caused by fluids and cells that are leaking from the local blood vessels to the extravascular spaces. And why are these fluids leaking? Well, they're trying to either go to that area of inflammation or they're trying to leave that area of inflammation. And then finally, we have pain or dolor. And I'm sure we've all experienced pain in our life. Some of us may be in pain sitting here listening to this lecture right now. But pain can be induced by many ways, as you know. So the erythema is the redness or the rubor. The heat is the hot sensation or the color. The edema is the swelling or the tumor. And the pain is pain, also known as dolor. And one thing I forgot to mention on the previous slide is that there's actually a 5th cardinal sign of inflammation, and this is the limitation of function. And termination of inflammation occurs when the injurious agent is removed. So now let's talk about this slide, which depicts acute versus chronic inflammation. So what is acute? That means it's sudden, it's a short duration. So you may have these quick events happening, maybe the leukocytes, such as the neutrophils and the polymorphonuclear leukocytes, are quickly migrating to this area, and they destroy whatever infectious agent may be there, and the body's able to recover. Maybe we only have some cytosolic swelling, doesn't damage the nuclei, and our body's able to easily restore itself. Versus in a chronic inflammation, well, the acute response is not working. There's some type of infection that's persisting over a long period of time. So there's going to be many of the different leukocytes present. You're going to get proliferation of the blood vessels, there may be fibrosis, those sorts of things. So there also may be a form of a granuloma. I showed you a picture of the lungs that had a granuloma formation with the cheesy or the caseous necrosis. So granulation tissue is made up of proliferating endothelial cells and fibroblasts, and it's seen in areas of chronic inflammation. The granulation tissue can be seen in well-healing open wounds, and also new capillaries and a granular surface composed of newly formed collagen can be seen. So the presence of granulomatous inflammation is clinically important because it aids in the diagnosis of the injurious stimuli. This is seen in tuberculosis and with the presence of a foreign body such as a suture. And what I want you to know mainly from this slide is like what are the hallmarks of chronic inflammation? Hallmarks are the accumulation of the macrophages, the lymphocytes, as well as the plasma cells. So when we have all three of these cells present, these cells are indicative of chronic inflammation. So again, with the acute inflammation, we only have some of the very brief first responders coming, the neutrophils, the polymorphonuclear leukocytes, compared to the chronic inflammation when we have the macrophages, lymphocytes, and plasma cells. And we're going to talk about how the plasma cells release antibodies to protect our body from antigen invasion. And chronic inflammation can contribute to the healing of injured tissue, but it's usually without a full return of function, unfortunately. So the proliferation of the endothelial cells reconstitutes the vasculature in the injured tissue, whereas the proliferation of the fibroblasts and the production of collagens and proteoglycans, which are the polymers that form the gel between collagen fibrils, they were going to reconstitute the extracellular matrix. And together, these constituents make up the granulation tissue and lead to the formation of a connective tissue scar. This process is regulated by growth factors that are derived from the macrophages and the platelets as well as the plasma. So again, I want you to be able to know what three cells are present as the hallmark of chronic inflammation. And again, they are the macrophages, the lymphocytes, and the plasma cells. So if we have an inflamed blood vessel, what are we going to see? You can see a normal pathology on the top of the screen, and you can see the inflamed pathology on the bottom of the screen. So first, we're going to have arterial dilation. What happens when our arterioles dilate? Well, that allows for more blood to flow through. So if you compare the bottom picture to the top picture, you can see that everything, the arteries, the capillary beds, and the venules are all dilated. So the capillary bed is going to expand as a result of the increased blood flow due to the inflammatory event. So vascular dilation and the increased blood flow, that causes erythema and the warmth. Remember, those are two of the cardinal signs that we talked about. And then the extravasation and the extravascular deposition of the plasma fluid and proteins, that causes the edema. And then the leukocytes will emigrate and they will accumulate at the site of the injury. So the proper order of structures that an RBC a red blood cell would encounter in the normal pathway of circulation would be the arteries, then the arterioles, and then the capillary beds, and then the venules, and then the veins. Acute inflammation can last from a few minutes to a few days during a time series where a whole bunch of different vascular events are occurring. And the goal of the series of the vascular changes is to increase the movement of the plasma proteins and circulating cells out of the intravascular space and into the site of injury. The escape of fluid protein and blood from the vasculature into the tissue or body cavities is known as exudation. And exudation occurs when there's an increase in capillary permeability, which allows for the proteinaceous fluid and or the cells to leak out of the openings that are created between the adjacent endothelial cells in the capillaries or the venules. So this schematic is really nice to show general tissue injury and how it could result in acute chronic inflammation, as well as how the healing process happens. So I like to talk a little bit about, baseball here again, played baseball in college, had lots of injuries, can't hold my arm straight now because of the amount of injuries I had. So if you look at how the injury occurs, well, obviously it starts off as acute. So maybe you're pitching for a little bit and you start to get sore. Well, that soreness accumulates and you don't really treat it. You don't do your physical therapy. You don't use the proper stretching methods that you should have. So the injurious agent isn't removed. So if the injurious agent persists, then chronic inflammation develops. As the chronic inflammation develops, you may see different features of granulation. Again, the 3 cells that I want you to know that highlight or hallmark chronic inflammation are the macrophages, the lymphocytes, and the plasma cells. So you'll see presence of these. They'll undergo some type of systemic organization, and they'll eventually contribute to the process of scar formation. And as many of you know, many of you have experienced scars, they could limit the possible function and mobility and outcomes of range of motion, many things in the body. So it's important to address the injurious agent as soon as possible and remove it so that we only get a little bit of necrosis or a little bit of abnormal cell migration, and that way we're not having any nuclear damage and we're able to restore the normal structure and function of the cells that we initially damaged. There are many different contributing factors and components of inflammation, and I'm sure that you all can list many that aren't even listed on this screen here. However, I do want to direct your attention to the top medial aspect of the screen where it talks about factors affecting blood flow. Histamine, for example. So when we release histamine internally, what does that do? That causes vasodilation and increased vascular permeability. Too much histamine release could result in edema. So how do we combat that? Well, we give an antihistamine such as Benadryl or diphenhydramine. I do want you to note that the vascular alterations associated with the factors affecting blood flow, the vasoactive mediators leading to edema, and the factors attracting and stimulating cellular alterations such as the chemotactic factors, can result in acute and sometimes chronic inflammation. This picture here depicts the main components of the ECM, or the extracellular matrix. And the extracellular matrix includes the collagens, the proteoglycans, as well as the adhesive glycoproteins. So both the epithelial and mesenchymal cells, such as the fibroblasts, they interact with the extracellular matrix through these components known as integrins. And the basement membranes and the interstitial ECM have different architecture and general composition, although there is some overlap in their constituents. For the sake of simplification, many of the ECM components, such as elastin, fibrillin, and syndekin, are not included in this picture. Basically, what I want you to know is that if you have an injury where you do get inflammation, you break all the blood vessels, which draws out more fluid. So inflammation's causing blood vessel breakage, more fluids coming, resulting in edema. We mentioned earlier that the different leukocytes are going to move out of the blood vessels and go towards the site of inflammation. So how do they do that? Well, there are many different chemical substances that can cause the neutrophils and the macrophages to go to this site. This whole process is known as diapedesis. So when the macrophages are moving out of the blood vessel towards the chemotactic source, that's diapedesis. But how they're actually directed, that's chemotaxis. So they are directed by some type of chemotactic input. So diapedesis is them leaving the blood vessel due to some type of inflammation, and chemotaxis is kind of the pinpoint GPS director to the source of inflammation. And chemotaxis depends on the concentration gradient of the chemotactic substance. The concentration is greatest near the source, which directs the unidirectional movement of the white blood cells. So chemotaxis is effective up to 100 micrometers away from the inflamed tissue. And because almost no tissue area is more than 50 micrometers away from a capillary, the chemotactic signal can easily move vast numbers of white blood cells from the capillaries into the inflamed area. And if the inflammatory stimulus will eventually subside, the neutrophils will then die off and they're replaced with monocytic macrophage cells, which are going to be responsible for cleaning up any of the remaining bacteria that are present. This slide is a nice depiction of the different outcomes of acute inflammation that can occur. So acute inflammation, we're going to have some type of resolution. So we're going to have the resolution by the simple clearance of the injurious stimuli. We could resolve by fibrosis, or we could go into chronic inflammation. So ideally, we want to go directly to the resolution stage and eliminate going into the fibrotic or chronic inflammation stages. I'm not going to test you on anything specifically. I just want you to know, again, that the desirable outcome is immediate resolution, but if acute inflammation persists, it can lead to chronic inflammation, which can cause the pus and the abscess formation, and eventually leads to fibrosis, which results in collagen deposition and a loss of function. The tissue healing process is a very complicated and complex process, which is influenced by many different components such as fibronectin, proteoglycans, elastin, collagen, and parenchymal and endothelial cells. So what happens in tissue healing is the phagocytes begin to secrete enzymes that break down cellular debris and dead tissue. The proteoglycans help to stabilize the tissue that is undergoing the repair, and they also stabilize collagen once the healing process is complete, and this creates an electrical charge that gives the basement membranes the property of functioning like molecular sieves. Proteoglycans also retain water, and they also aid in the hydration of the tissue being repaired. Collagen, which is derived from Greek, means glue producer. So it's a fibrous protein molecule consisting of 3 chains of amino acids coiled around each other in a triple helix. And there are over 27 different types of collagen, so you don't need to know all of those. I just want you to know that there are many different types of collagen, and all of these players are involved in tissue healing. Now let's talk about leukocyte accumulations. So first off, what are leukocytes? So leukocytes are the different white blood cells that are present, and they can either be granular or agranular. I do want you to know the difference between the granular leukocytes versus the agranular leukocytes. So the granular ones, I always remember my grainy friend Ben. Ben he was just this nerdy guy. He was very grainy. And Ben, B-E-N. So basophils, B, eosinophils, E, neutrophils, N. So the other leukocytes, such as the T cells and the B cells, or the T lymphocytes and the B lymphocytes, those are agranular. So the accumulation of leukocytes, again, that's diagnostic of the inflammatory process occurring. And during acute inflammation, we have what is known as neutrophilia. So neutrophils are going to inhibit bacterial growth by releasing a protein known as lactoferrin, which binds with iron and prevents microorganisms from using iron for growth and development. Neutrophils also have the capability to demonstrate direct cytotoxic activity towards viruses, fungi, and bacteria by releasing defensins, which are peptides with natural antibiotic activity. So the stasis simply means the slowing or the cessation of blood flow in the affected vessels. The adhesion glycoproteins are the glue that binds the leukocytes to each other and to the endothelium of the venules and the capillaries. The binding of the leukocytes to the receptors on the endothelial cells of the venules is the first step in the migration of the leukocytes from the vasculature to the interstitial tissues. This process initiates the circulation of leukocytes through the extravascular space in normal conditions, as well as the infiltration of leukocytes into the site of inflammation itself. In the next stage, the leukocytes actively migrate out of the vessels via diapedesis, passing through the vascular walls without damaging the blood vessels, and then they enter into the interstitial space. The continued migration of the leukocytes in the interstitial space is directed by a chemical trail created by a concentration gradient of many different types of attractants, and this process is known as chemotaxis. The main function of the leukocytes is to remove or to eliminate the injurious stimuli. The leukocytes have the capability to release enzymes and other toxic substances that kill their desired targets. And the leukocytes take up these materials through a process known as phagocytosis, and they release growth factors necessary for healing or regeneration. So a few terms I do want you to know. I do want you to know the differences between leukocytosis and leukopenia. So leukocytosis, we have an increased white blood cell count, and this is indicative of the inflammatory reaction occurring. In contrast, we have leukopenia. This is a decreased white blood cell count. And leukopenia can also be seen in inflammation, as it is an indicator of grave prognosis in sepsis. And I do want you to know what the lymphatic system is. We're going to talk about this more in anatomy, but the lymphatics help to drain the fluid and protein from the interstitium, and because they have that capability, they also have the capability to reduce edema. And if there's any type of hyperplasia that occurs, especially in the immunocompetent cells, such as the T and the B lymphocytes, this can lead to lymphadenopathy. The leukocytes, or the white blood cells, are also known as cytokines, and these cytokines can elicit effects through two main ways. They can elicit either autocrine effects, meaning they have an effect on themselves, or they elicit paracrine effects, meaning they have effects on adjacent cells. And there's a number of systemic hormonal inflammatory effects that are mediated by the cytokines. And there are as many as 15 known interleukins. I really just want to focus on IL-1 and TNF, tumor necrosis factor. Tumor necrosis factor can do everything IL-1 can, except it cannot activate lymphocytes. That will be a test question. TNF can do everything IL-1 can, except activate lymphocytes, cannot activate the white blood cells. So IL-1 has the capability to cause fever by raising the production of prostaglandins in a brain region known as the hypothalamus, and IL-1 can also cause changes in blood chemistry. As I mentioned earlier, there are many different types of collagen that exist in our body. And remember, collagen is an essential structural entity in the body. It provides the structural support and the necessary tensile strength for many different components of the body. And as you can see here, there are many different types of collagen. I will only test on collagen types 1, 4, and 10. So why am I testing in type 1? Well, this is the predominant structure in the body. Type 1 collagen, this is about 80 to 85% of the collagen that we find in our body. This is the dermal collagen. This is also the collagen that you'll see in mature scars, and the collagen that you'll see around the tendons, the bones, and the joints. Type 4, we're going to talk about type 4 because that's found in all the basement membranes, and we're going to talk about the integral structure of why the basement membranes are so important in maintaining homeostasis. And this type 4 collagen is also found in the glomeruli of the kidney nephron, which we're going to talk about in the renal section. And then type 10. Type 10 is interesting because it's only formed in the epiphyseal growth plate cartilage. and it may have a role in angiogenesis. So we're going to talk about two disorders. We're going to talk about acromegaly versus gigantism, and these two disorders are differentiated by when we see the growth. Is it before the epiphyseal plate closing or after the epiphyseal plate closing? So we get gigantism if we see the growth before the epiphyseal plates close, and we get acromegaly if we see growth, excessive growth, or excessive hormonal production after the epiphyseal plates close. So that's why type 10 collagen is very important. So you will be tested on type 1, 4, and 10, so please know those types. And as you all are going to be clinicians soon, you all have to know that there are many different factors that influence how a bodily injury heals. So everybody that you're going to see is different, and you have to understand that, respect that, and it's very important for you all to know all of the different pathological conditions that these patients may present to you with, because they may have some factors that may accelerate wound healing, or they may have some factors present they may decelerate wound healing. For example, it's very important to get a complete medical history. Ask the patient if they use tobacco or alcohol or caffeine or other illicit drugs. There's many research articles that show that alcohol and tobacco decelerate the process of wound healing. It's very good to work with a dietitian and a nutritionist as we get this holistic approach towards healthcare and trying to get the patient better. If the patient has some type of nutritional imbalance, the patient may not heal as well. And what type of tissue? Is it a superficial wound? Is it a very deep wound? Is it a diabetic ulcer? So all these different possible complications and injuries exist, and all these different tissues have the different healing times and capabilities. And in the next few slides, we're going to talk about the phases of healing and how the body recuperates from injurious stimuli. Now let's jump into the different phases of healing. So immediately after an acute injury occurs, hemostasis is going to occur in order to attempt to stop the bleeding by initiating coagulation. The platelets are going to release bioactive proteins that can act as chemical messengers that summon inflammatory cells to the wounded tissue. Growth factors are going to play their role by stimulating proliferation and migrations of different epithelial cells, fibroblasts, as well as vascular endothelial cells. They also help to regulate the differentiation of cells, such as the expression of the extracellular matrix proteins. So as the blood is filling the area, the coagulation cascade is then going to stop, the platelets are going to clump, and eventually a blood clot is going to form. However, eventually we need to remove that blood clot, and that is removed through a process known as degeneration. And the degeneration stage is characterized by a hematoma, which is a necrosis of dead cells and the start of the inflammatory cell response. And the tissue is going to be repairing itself, or attempting to repairing itself, when the fibroblasts migrate to that area. So the migration of the fibroblasts begins within 24 hours of the injury, and the fibroblasts release different factors to reconstitute the extracellular matrix and provide the framework for developing endothelial as well as parenchymal cells. So the phases of healing: we initially get the injury, we go through hemostasis, we go through the blood clotting cascade, then we go through degeneration, and then finally tissue repair. So in the inflammation stage, this is when the clot is formed, or in the process of forming. And what happens during this phase is there is usually vasodilation around the area of injury. And vasodilation will allow and activate the movement of the polymorphonuclear leukocytes as well as the macrophages to the wound site. So now we have leukocytes and macrophages going towards the wound in the attempt to destroy the bacteria and release proteases and secrete additional growth factors to help destroy whatever infection is there. The growth factors, the cytokines, and the chemokines are the key molecular bioregulators of the inflammatory phase of tissue healing. So 5 days after the injury, the fibroblasts, as well as the epithelial cells and the vascular endothelial cells, move into the wound to form the granulation tissue. And there are some extracellular matrix constituents that I want you to be aware of. The basement membranes deposited by the endothelial and the epithelial cells that provide the mechanical support for resident cells and function as a scaffold for accurate regeneration of pre-existing structures of tissue are made up of 4 types of collagen and different types of proteoglycans. So where there is this extracellular matrix component that is very important in the inflammation stage of tissue repair. Now let's move into proliferation and migration. So within 2 days after a skin wound or injury occurs, the endothelial cells from the viable blood vessels near the edge of the necrotic tissue begin to proliferate. Within the vascular network, there's oxygen and other types of nutrient transport that help support the metabolism of the healing tissues. And eventually, new capillary channels will form and merge to develop and grow towards the tissue defect, which is caused by the initial injury. Initially, the newly formed vessels are leaky, which contributes to the edema that's around the tissue that's undergoing the repair. And as the tissue healing becomes completed, blood flow to the newly formed vasculature shuts down and the non-functional vessels are degraded, leaving only a few vessels in the mature scar. And any type of damage matrix will begin to undergo removal as the new matrix begins to fill the wound, and proteases secreted by the neutrophils, the macrophages, fibroblasts, epithelial cells, endothelial cells will help to destroy any remaining bacteria or pathogens in that specific area. And that is also how the damaged matrix proteins are eventually removed. So after the proliferation and migration phase, we go into the remodeling and maturation phase. So the scar tissue that's just formed is going to be reduced and it's going to be remodeled. There's going to be a concentration of blood vessels in the area, and this concentration of blood vessels is going to be decreasing at this time, and the scar tissue will begin to go back towards the color of the person. So if you're lighter skin, you may start to develop lighter colored scar tissue, versus darker skin, you may begin to develop darker scar tissue. And as the healing process proceeds, the newly formed extracellular matrix draws together, and this causes shrinkage of the healing tissue. The myofibroblasts contain abundant contractile proteins and apparently contract and contribute to the shrinkage of the healing tissue. When we refer to the word contracture, that means excessive shrinking of the healing tissue that occurs in addition to the pulling of the deeper tissue to approximate the healing site. So there's this extra force, there's this extra contracture that is helping the whole healing process happen. This is undesirable in most cases because it can limit mobility and organ function, and it can also be disfiguring. And contracted tissue can also occur with excessive arthrofibrosis. And arthrofibrosis usually occurs in the shoulder and the knee after some type of orthopedic surgery. After the remodeling and maturation phase, we have what is known as tissue regeneration. So not all cells have the capability to undergo regeneration, or we're talking about neurons, not all neurons have the capability to undergo neurogenesis. That's why neurons are termed permanent cells. However, there is some literature that shows that some neurons in specific areas of the brain have the capability to regenerate themselves. However, that literature is very limited and is also very controversial at this time. And we don't know how it works in humans. It's only been developed in certain mammalian models. So other examples of permanent cells, which technically do not have the capability to regenerate, are the cardiac myocytes and some of the peripheral neurons as well. The labile cells, the cells that are actively undergoing division, these have the capability to regenerate. These examples include the epithelial cells of the skin and the GI tract, and as well as the bone marrow. So these cells are continuously dividing. Another example of a labile cell is a hematopoietic stem cell. And then we have the stable cells. So the stable cells, they don't normally divide, but they can be induced to undergo mitosis if there is an appropriate stimuli. And these include the hepatocytes, the skeletal muscle fibers, and the kidney cells. So again, the stable cells, they're pretty stable. They don't want to divide. They don't want to regenerate. However, if there is an extreme lack of them, the body can send intracellular signals and tell itself to undergo mitosis in these specific cells. And these cells do have the capability to regenerate. So I do want you to know the differences between permanent, stable, and labile, and know the examples that I gave. So again, the permanent, I gave the cardiomyocytes and the neurons. The labile, I gave the epithelial cells of the skin and the GI tract, as well as the bone marrow. And the stable cells are the hepatocytes, the kidney cells, the skeletal muscle fibers, and things along those lines. So please know the differences between these cells and what classifies these cells in each condition. How a scar actually forms is a very interesting process. When we're injured and we have a deep wound, wounds really have to heal from the inside out. Skins can still heal without scarring, but without this specific matrix that we have in our body, the labile cells don't regenerate, or else they would regenerate in an incomplete fashion. Careful attention to homeostasis minimizes the deposition of blood into the wound, and proper sutures with appropriate tension from the orthopedic surgeon's behalf are key to limiting the appearance of the scar and also for allowing the tissue to heal properly. So let me focus your attention to the schematic now. The schematic labeled A is what happens when we heal under primary intention. And this happens when it's not a wound that ever gets infected or anything like that. It's just a wound that heals in perfect chronological order. So healing by primary intention is the initial union of the edges of a wound, and they progress to complete healing without granulation. So in primary intention, there's no granulation. If you look at the row B, this is healing by secondary intention. And what happens here is the wound is closing because the edges are very far separated, so the edges have to use more effort to come together. And because they don't come together immediately, what happens? The granulations tissue starts to fill the gap, and the epithelium grows in over the granulations. And as the epithelium grows in over this granulation, that's what produces a scar. And then if you look at row C, this is what happens. This is known as tertiary intention. So you see the same thing as in B. We have a wound, the granulation tissue with thick edges. However, this wound is contaminated. Maybe there's some type of infection present. So what happens is the granulation tissue, just as in row B, will fill in the gap, and the epithelium will grow in over this granulation tissue just at a slower rate, and it will actually produce a larger scar. The scar will have a delay in closure, and the wound may have a significant delay in overall healing because of the contamination. So proper wound care and closure is essential so that we try to get healing by primary intention as our main focus every single time. We never really want to go into healing by tertiary intention. Some of you may have seen this condition before that's depicted here. This is known as a keloid or a hypertrophic scar. And this scar is mainly composed of type 3 collagen. I will test what type of collagen makes up a keloid. So in addition to knowing types 1, 4, and 10, you also have to know that type 3 makes up the keloid. And why do keloids form? Well, they form as a result from defective remodeling of scar tissue and the persistence of this type 3 collagen, which is typical of an immature scar. The epidermis is elevated by excess scar tissue, which may continue to increase long after healing occurs. And keloids can have all different types of looks and appearances. However, the majority of them look smooth, rubbery, and kind of claw-like. Unfortunately, young women and the African American population, as well as people of Mediterranean descent, are particularly susceptible to keloid formation. This is an interesting slide because I've just kind of highlighted how different organs and different tissues here, and bone as well, are repaired, and the processes that they have to undergo to achieve proper repair. So in all of our tissues, all of our body, the main attempt is to restore the injured tissue to its optimal function. In the lung, we're going to talk about the type 1 and the type 2 alveolar cells. So type 1 alveolar cells, or the type 1 pneumocytes, they permit gas exchange, and the type 2 are very important for producing surfactant. So it's very important for the basement membrane to be intact, or these alveolar cells will never have the capability to regenerate. If you're not getting proper regeneration of gas exchange and surfactant, there's going to be a lot of respiratory complications that are going to arise. If the basement membrane is damaged, there must be some type of repair, and that repair is going to result in either a fibrotic repair or a scar formation. The small intestine and the digestive tract as a whole is very dynamic and a very regenerative organ as a whole. Every 4 to 5 days, the villi slough off, and every 3 to 4 weeks, every month, you have brand new villi generating in your gastrointestinal tract. When a peripheral nerve is cut, it rapidly undergoes myelin degeneration. So remember, the myelin is the sheath that is encompassing the peripheral nerve that allows, so the more myelin you have, the quicker neuronal conduction can be, especially in both the peripheral and the central nervous systems. So when the peripheral nerve is cut, the myelin starts to degenerate rapidly and the axons begin to fragment. The lipid debris is going to be removed by macrophages mobilized from the surrounding tissues. And this is known as Wallerian degeneration. So within 24 hours of this injury, new axonal sprouts from the central stump are observed with proliferation of Schwann cells from both the central and the peripheral stumps. A little bit of neuro, you don't need to know that, that's just for your reference. Skeletal muscle. Skeletal muscle is composed of both contractile and connective tissue. It can regenerate, but it also depends on the severity of the injury. Is it a simple strain or is it a severe contusion? And what type of cells are involved in skeletal muscle regeneration? We're going to cover the satellite cells and neuro, so I'm going to talk about that here. And bone. Cortical bone makes up 80% of the skeletal tissue. The tough outer layer that is densely packed and surrounds the cancellous bone is the cortical bone. So you don't want to, it's a protective mechanism. And the bone has two surfaces. We're going to talk about the periosteal and the endosteal surfaces of the bone. So it depends on where the injury is and whether there's proper bone remodeling. What's happening with the osteoclast and the osteoblast formation? So remember, osteoblast, that has a B, it builds the bone. Osteoclast, they break down the bone. So if we have more osteoclast activation than osteoblast activation, we're going to have a severe breakdown in bone. So there's a lot of different mechanisms. I don't need you to memorize anything here. I just want you to know that there's different mechanisms of repair in each specific tissue and organ system. Tendons and ligaments. Remember, we covered ligaments on the first day of anatomy class. Ligaments attach bone to bone, while the tendons attach muscle to bone. And they are made of dense bands of fibrous connective tissues. and they have parallel fibers of type 1 collagen. Remember, type 1 collagen is the predominant form of collagen that we see in the body. It makes up 80 to 85% of the body. And tendons have the highest risk for rupture. So the composition of the tendons and the composition of the ligaments allows them to sustain high unidirectional tensile loads. It also allows them to transfer forces and provide strong flexile support and help the tissue respond to normal loads while resisting excessive mechanical or shearing force and deformation. So what's a tendinopathy? A tendinopathy is a degenerative process with little or no inflammation, but histopathologic conditions and changes in the collagen matrix. And tendinopathies may or may not be painful. Now, what happens when our ligaments are injured, and how do our ligaments heal themselves? So ligaments are susceptible to all types of injury. They're susceptible to sprains and tears. Tears could be first, second, and third degree tears, and I'm sure you'll cover that more in kinesiology and musculoskeletal. But depending on the changes in the structural or the biomechanical integrity, that's really going to facilitate how long healing takes to occur. And it could range from an injury of a few fibers without loss of integrity, which would be a very quick healing process, to a complete tear, which may be a very prolonged healing process. So shown here is a picture of the knee, and let me direct your attention to the anterior cruciate ligament, or the ACL. The ACL has a very, very poor healing response. And the reason it has a poor healing response is because after the ligament ruptures, it has a very thin synovial sheath, and this thin synovial sheath is disrupted. And when the synovial sheath is disrupted, blood's going to dissipate out. And what happens when blood dissipates out? Well, a clot can't form. And if a clot can't form, a hematoma is likely going to form. And then healing of the ligament can't take place without a foundation for repair or localization of chemotactic cytokines and growth factors. And the ACL itself, during injury, will release large amounts of matrix metalloproteinases after injury, and these matrix metalloproteinases are involved in extracellular matrix turnover. So the ACL itself is destroying any type of extracellular matrix that may be there and preventing new ECM from forming. This slide here is just a diagrammatic representation of the distribution of collagen fibers in the meniscus of the knee. So collagen is oriented throughout the connective tissue in such a way as to maximally resist the forces placed upon these tissues. The majority of type 1 collagen fibers in the meniscus are circumferentially arranged, with a few fibers on or near the tibial surface, and these fibers are placed in a radial pattern. This structural arrangement enables the meniscus to resist lateral spread that occurs during high compressive loads generated during weight-bearing exercises and activities. The longitudinally arranged collagen fibers facilitate shock absorption and sustain the tension generated between the anterior and posterior attachments. And finally, we are going to conclude today's discussion by talking about the effects of prolonged immobilization. So again, you don't have to know exactly every single result of immobilization. I just want you to look at this chart and kind of familiarize yourselves with what could happen. So from muscle, for instance, we gave the example of the runner who was an avid runner, and all of a sudden he or she got hurt and was unable to run and started to experience atrophy of the running muscles, the gastrocnemius, the quadricep, the hamstring, so on and so forth. So just take a moment, look at the effects of a prolonged immobilization, and that will cover all of Chapter 6, everything that I want you to know for the exam.